Good day, friends. As usual, we will start with a prayer. O Almighty, may He protect all of us. May He cause us to enjoy. May we acquire strength together. May our knowledge become brilliant. O Almighty, may there be peace, peace, peace. Friends, I am leaving this slide and the information also will be recurring in different slides as to how to contact me. Because many times I get messages, somehow or the other people try to reach me in different ways. I am making it easy from them. This is the way you can send in your queries. This is my email ID. I have a YouTube channel on which this video is coming. I have a website from also where you can access me, and I am also easily available on Facebook. Friends, I have always felt that success makes us happy, but it is a failure which teaches us. Many times in our clinical practice, we get situations where we get completely exhausted. And that is the time what is most difficult is to handle it with a clear mind. If we can handle any situation with a clear mind and take a timely decisions, then I am sure many of our problems can be easily handled. The topic for this discussion is relaparotomy in gynec practice. The more interesting topic would be, why did they operate on her again? It is in a situation analysis format where I will be bringing out a situation, and then after I will be discussing with you how to solve it. Let us see the first situation. A patient was operated for dysfunctional uterine bleeding. Hysterectomy was uneventful. Immediate postoperative period was normal, except for a complaint of pain at wound site, which is routine and can be handled very easily with analgesics. On third day prior to surgery, the patient started off complaining of severe pain and strangury. Now, this strangury and tenesmus are two very important clinical signs. Strangury is suggestive of a pelvic hematoma in the anterior pouch, and tenesmus in the pouch of Douglas. If they are not there, that doesn't mean that there will not be a hematoma. But if there is a hematoma, if there is a strangury rather, or a tenesmus, and or a tenesmus, then think of a pelvic hematocele. Because of that reason, a USG was done, and the sonography showed a large heterogeneous echogenic area behind the bladder, possibly a collection of blood. Now the question you would like to ask is, what happened? Let us analyze. The patient was operated upon again, and it was found that there was a hematoma behind the anterior peritoneum, probably from an ignored small bleeder in the visceral peritoneum. This hematoma was evacuated. So what must have happened? The analysis comes here. Many times when we are doing a surgery, at the lower end of the incision, we put a right angle retractor or a Deaver's retractor, or maybe sometimes even the bigger one which we use for cesarean section. Those different retractors are placed there. Now, when we are about to finish the surgery, we remove the retractor and we forget to look at the visceral peritoneum there. It just slips there, and there might be a small vessels there. These vessels tend to get ignored. One point is that the surgery is over now, let us finish up. The second one is our reflex. This will come around. It doesn't come around. It just doesn't come around. Howsoever small it may be, you might be accused by your juniors, or if you are a professor or an associate professor or a teacher, to be short, in short, at a medical college, you might be accused of being what they call as, he is trying to catch RBCs, but so be it. The field has to be completely dry. Then only close the abdomen. That was probably not done in this case. And a small vessel went on seeping, did not stop, and produced that hematocele. Hemostasis was ensured. Following re-exploration, however, the patient recovered uneventfully. Let us see the next situation. The next situation is a result of these structures, the adhesions. Adhesions, I always find, are actually villains. And why I call them villains is because they do things which they are not supposed to do. They are present where they are not supposed to be. And they create problems which are many times not easily solvable. This is a case of a 39 years old lady who underwent an abdominal panhysterectomy for endometriosis. There were adhesions in the pouch of Douglas which were laced with sharp dissection. Sharp dissection is always better than blunt. I have always felt that blunt dissection sometimes reflects our fear to dissect. And as a denial of reality, we just tend to go through and expect that, oh, this, and wish that it will go away. Sharp dissection requires a very beautiful and a precise tissue identification and a perfect cut, a bold, sharp cut. This was done in this patient. 6 hours after the surgery, the patient complained of vomiting 3 to 4 times. Antiemetics were given. Probably it was thought that this is routine post-operative because so many drugs are given during surgery and before or after it. And there might be gastritis and she vomits. Or some drugs might be having some side effects. There was no distension of the abdomen at this stage. Peristalses were present. Vomiting subsided. So all was well, hunky-dory, everyone went to sleep. 24 hours after the surgery, the pulse was 104 per minute. Blood pressure was normal. Abdominal girth had increased by 5 centimeters. Peristalses were, however, present. Probably an adynamic ileus, probably a dynamic ileus, we don't know. Patient was put on light diet. Now this is important. The pulse was 104 per minute. Actually, at this stage, for an uneventful surgery, the pulse should have been below 100. 88, 84, it teeters around. And I always have learned that never ever ignore a pulse and never ever ignore a round. What I mean by it? That a pulse which is more than normal, what is expected of that day and of that surgery, always be alert. And a round, by a round I mean a hospital round or a ward round. So many times I have seen, or experienced also, that when we feel that everything is settled, let us not go for the round, let us bunk the round today, or let us avoid the round, or let us dispense with the round today, everything is fine, this evening round or afternoon round, whatever routine you are taking. In fact, that is the time when the complication actually occurs, has occurred, and you miss it. So therefore, I always feel that never ignore a pulse, never ignore a round. See now, then after what happened? 48 hours after the surgery, the pulse was 108 per minute. You can call it a same 104, 108, but it was not coming down. Blood pressure was normal, no fever, and this was one more sign that the distension persisted by 5 centimeters. This must be some old-timer clinician who actually used to measure the abdominal girth. It's a very good habit, where at the level of the umbilicals, or the maximum distension, the measurement is taken by the measure tape. I know of some surgeons who immediately post-operatively leave a measure tape behind so that you don't have to lift the back of the patient to pass it when he feels or suspect a distension. And they regularly take an abdominal girth. Here, it persisted by 5 centimeters. Similar findings remained till the 5th post-operative day. She surely now looked sick. Distension also persisted. The question before the team was, what should be done? Well, this is where decision making and a timely decision making comes in. Decision making is always difficult. Once the decision is made, then executing the decision is very easy and very peace-giving. A re-exploration revealed fecal peritonitis. There was a small injury to the rectum during the which occurred during the causal dissection of the adhesions. Adhesions caused this. Therefore, they always say that when you require adhesiolysis, always examine the bowels after the dissection if there is any doubt, or if the adhesions were very complicated. Usually, after such a surgery of adhesiolysis and hysterectomy and so many things involved, endometriosis, usually we get tired, and that is where human psychology steps in. We want to close fast. Come on, let us get away with it. Let us get over with it. And this is where these things are missed. Let us see the next situation where we want to know why this woman was reoperated. A patient underwent a vaginal hysterectomy for 2nd degree uterine prolapse. There was no intra-op complication. Following surgery, the pulse was 100 per minute, blood pressure 100/70. A vaginal hysterectomy, so-called uneventful vaginal hysterectomy. There was mild pallor. 2 hours of the surgery, patient's pulse was 120 per minute, blood pressure was 90/60. So the surgeon thought that this might be spinal hypotension. Not very likely 2 hours after if it has been handled well during the surgery. IV fluids were given. Blood pressure now was 100/70. After 4 hours of surgery, pallor had increased. This is the gut feeling. This is the clinician's feeling. Pallor has increased. No objective investigation has been done, but her pulse was 120 now, and the blood pressure fell to 90/60. Ultrasound carried out which showed no free fluid in the peritoneal cavity. The flank puncture was also negative. So the team got together and said, what should be done now? This is where analysis comes in. One thing was sure, she was bleeding. She was bleeding somewhere, and that was beyond doubt. But where? A calm analysis of the team would surely reveal that in the extraperitoneal space, there is an inaccessibility, and it is even missed on ultrasound. And that might have occurred. Wisely, the team reopened her up. It showed a huge broad ligament hematoma which was missed on ultrasound. It was not possible to ligate the vessel, so they did a bilateral internal ilia. I always feel that these routine surgeries are where many times very vicious complications occur. Routine surgeries are those where we don't care much. Not that we are careless, but we are not over alert as we are in complicated surgeries. That time can be wasted because of this. Because of routine surgery, nothing is expected. And the second philosophy, or second thinking rather, is it will come around. This it will come around is dangerous. I have told this even in the first discussion about that seepage below the Doyen's retractor or the Deaver's retractor which we use. And that caused a hematoma. A small bleeding, it will come around. That is not what is worth doing. In the next situation, which we are going to see, where she was opened up again, was most unexpected, like this picture. What happened was, there was a patient who was operated for fibroid uterus. Abdominal hysterectomy was done. Immediate post-operative in the OT, there was bleeding from the angle. Probably it was not secured properly. The wall It was then secured vaginally, as we do. In the operation theatre itself, position was given and vaginally it was sutured. 6 hours after the surgery, the pulse rose to 100. The blood pressure was 100/70, but there was no abdominal distension. This is where the concept of hidden blood loss comes in. Recently, I was reviewing a research paper for a journal where hidden blood loss was investigated. And they quoted a very staggeringly high figure of 14 times the obvious blood loss. This data was false, was dirty, and I had to reject it. But that is not important. What is important is that hidden blood loss is a reality. Therefore, in many institutions, I have seen that post-operatively always a hematocrit is repeated. It's already done before and afterwards, and there are formula available where they calculate the hidden blood loss from the fall of hematocrit, and accordingly they decide as to how much she has lost, and if at all she requires a replacement. This patient was looking pale. So 2 units of whole blood was administered. Ultrasound revealed no abnormality. On the second post-operative day, the patient had 3 episodes of fever and had tachycardia. Her pulse was 120 per minute. There was no abdominal distension. Peristalses were fine. Apparently, the intestines were jumping around, but dancing around. Patient was put on light diet because this is the expected picture. Investigation for fever percent, which were normal, except the raised total blood count of 15,000. So she was put on higher antibiotics. Look at it in a way in which you would have encountered this case. You would have also done the same. On the third post-operative day, the patient had 4 episodes of high-grade fever, and the pulse was remaining 120, 128. There was no abdominal distension. Empirically, chloroquine was given that it could be malaria, though there was no evidence for it. Now one event after the other started. Therefore, it is always said that it is better to fit in one diagnosis rather than putting multiple diagnoses. When you put multiple diagnoses, you are very likely to go wrong, as it was done in this. On the 4th day following surgery, patient had complaints of bleeding per rectum. A stool examination was done, which was normal, except presence of blood in stool. X-ray abdomen showed my minimal gas under diaphragm, which is the imaging experts say this is a common finding following a major surgery, abdomen. But the gynecologist was not convinced. He got a colonoscopy and a proctoscopy done, and by the gastroenterologist, which showed blood in the rectum, but no other positive diagnosis could be made. The patient continued to have fever and bleeding per rectum even on the 5th day following surgery. Now the pulse was 132. No clue was coming, no lead was coming. There was no abdominal distension, but clinical condition remained the same. The total count shot up to 38,000 in neutrophilia. Patient was already on broad spectrum antibiotics. This made the gynecologist become edgy. At her wit's end, a re-exploration was carried out. At his wit's end, sorry. A re-exploration was carried out, which showed that the rectum was implicated in the stitch which was taken in the vaginal wall, and a small area of the rectal wall had undergone necrosis. So what must have happened? This gynecologist must have caught hold of that bleeding angle, pulled it a little, but taken a deep stitch so that once again it doesn't slip. This is our psychology. When we are doing a total laparoscopy hysterectomy, and we find that there is a bleeding point of a major vessel, we cauterize it. Then also it oozes because it tends to retract. We cauterize it much more than what is required, so that it should not bleed now. Similarly, the stitch was therefore taken deep inside that no tissue slips out. rectal opening was sutured. She required a colostomy. Patient recovered. Subsequently, colostomy closure was carried out after 6 months. Everything seemed to be fine. The next situation is where the complication was not entirely unexpected. It is expected. What was it? Let us see. A patient of cancer cervix stage 1B was operated, but hysterectomy was done eventfully. Immediately following surgery, the patient had a stable urine output of around 700 cc and she was also stable. 4 hours later, the patient was still stable, but there was no increase in urine output. Fluids were administered, diuretics given, but still there was no increase in urine output. Her serum creatine values were normal. For the hysterectomy, we do lateral dissection, and therefore the gynecologist requested a cystoscopy. And they found that on cystoscopy, the urine flow was not there. The ureteric catheterization was done, which suggested a bilateral ureteric obstruction. So they said, what now? After 12 hours, they opened up, following the discussion. It was found that there was a right ureteric transaction and the left ureter had been dilated. So this is what the ureter is. Apparently a friend which is so important for us, but can become a foe. Right ureteroureteric anastomosis was done. The stent was left behind. And the left side, there was only a simple ligation, so it was deligated. A stent was also placed. The patient had a normal post-operative outcome. Stents were pulled out after 4 weeks and she was fine. Recently, I had a scary situation. The patient was actually a case of scar pregnancy. For ruling out corona, we subjected her to a CT scan. At the same time, the imaging expert said that, sir, I am also doing a CT scan of the pelvis. Fine. And he identified that there were 2 ureters. On the right side, there were 2 openings. The left side, there was a single ureter. A picture similar to what is seen in the slide. I have put this case on my YouTube channel. You can subscribe to the channel. The channel is Pankaj Desai's channel. And the title is Caesarean Scar Pregnancy, a case report. And you will be able to see this. We confined our dissection medially, close to the uterus, and there was no problem. Let us see the next situation. This was really a tricky situation. It came to us from Calcutta. What was it? This patient was a known case of fibroid. She presented with pallor and pain in abdomen with a syncopial attack. A fibroid should not come with a pallor and a syncopial attack. Pallor if it is a chronic bleed. But with a syncopial attack and an acute pallor, not likely. The relative said that no, she was not looking so sick. A diagnostic laparoscopy confirmed a capsular rupture of fibroid. A total abdominal hysterectomy was done. Blood cleaned off from the peritoneal cavity. With normal saline, lavage was given. And finally closed up the abdomen with an active Redivac drain in situ. Very soon the sister from the nurse from the recovery room phoned up to say that the Redivac bottle was full and they were now changing it. It was assumed that this time was a normal saline which is coming, which was used for the lavage. But the sister called again, and I congratulate the sister. She was alert. She called again to say that the BP was quite low, and now she had a tachycardia. But since the drain was not draining, she was shifted to the ward. Meanwhile, her blood pressure remained low throughout the night. Blood transfusion was arranged. Now, there was a paradoxical situation. When the blood was being transfused, the patient was having severe tachycardia and the blood pressure was plummeting, falling down. After the transfusion, her BP and pulse would settle and would be reasonably fine. really makes us ask a question. What is happening? When you give blood, it should stop from becoming bad. In fact, it was here precipitating a crisis. An ultrasound scan was done, showing no collection in the pelvis. There was hardly any drainage, anything in the drainage. And despite this, the blood pressure and pulse were not recovering. A wise decision was taken. And 16 hours after the surgery, she was taken up. She was looking much more pale. The pallor was very marked now, and the blood pressure became not recorded. The team, in a state of confusion, but opened up. Benefit of doubt always in favor of opening up. She was opened up to the old suprapubic scar, means the old means that was taken for the hysterectomy. The stumps were fine, nothing much in the peritoneal cavity. There was no collection of blood also in the pelvis, but there seemed to be some fresh blood trickling down from the above. The incision was extended and finally found the bleeding point rather higher up in the inferior epigastric artery. A vascular surgeon was called, who came, just put in 2 silk stitches, and everything seemed to be fine. When the mind was applied or the brain was applied, all the jigsaw pieces fell in place. The artery had probably got nicked by the Weary's needle, but only partially. So the collection was mainly retroperitoneal. There was no collection in the drain, despite the falling blood pressure, and no fullness was felt in pouch of Douglas. There was no collection which was felt because there was no fullness felt. No collection was there because it was draining somewhere behind in the retroperitoneal space. Since the sheath was intact, when the blood volume was improving on transfusing, the artery would open up and bleed more, and when the blood volume fell, the artery collapsed. It was a partial cut. The patient remained in the ICU for a few days, but subsequently recovered. Let us see the next situation. This is where she was opened up after some time, after some months. Let us see what happened. So there was an event which took place in the past. The clock seemed to be going back. Mrs. I, 26 years old, gravida 4, para 1, MTB 3, was admitted in February with profuse vaginal bleeding for 2 weeks. She had undergone a first trimester MTB 7 months ago in July. At that time, she underwent a bilateral internal iliac ligation for a suspected cervical pregnancy for severe bleeding during MTB procedure. No histopathology records were available. She remained asymptomatic for 2 cycles, and after this irregularity and profuseness of bleeding began. Like a typical enemy hidden, it struck after some time. Clinically, she was pale when she came to the hospital. Hemoglobin 5 grams. Abdomen findings were apparently normal. For speculum examination showed a normal cervix. My friends who are watching this video, you might have started thinking of a cervical pregnancy. Please note, there was no congestion, no erosion, no growth or ballooning of the portia. Pervaginal examination showed a normal size firm uterus. Biochemical profile was normal. Pelvic ultrasound showed an empty, normal uterus. No adnexal pathology, and the cervix showed an irregular echogenicity within the matrix of 1.5 by 1.5 centimeters. Immediately, color power was given, and it revealed a leash of vessels and vascularity, suggesting an arteriovenous aneurysm. Probably this has resulted from some altered collateral circulation following bilateral internal iliac ligation last time when she bled. I would like to make a note here that the internal iliac ligation is a blessing. It has saved thousands and thousands of lives. But sometimes there can be complications. Rare complication. I know you can be rarely correct if you think of it commonly. But keeping it at the back of our mind helps, as it helped in this case where they opened it up. The technique of uterine artery embolization after the vessels have been catheterized under fluoroscopic visualization is being used with increasing frequency to treat such type of bleeding. But this patient did not want to preserve fertility and she opted for a hysterectomy. So, a procedure which is a blessing can also sometimes rarely become a curse. Let us now come to the last situation. And this situation is has one unsolved mystery. What is it? Let us see. A 49-year-old patient presented to the OBGYN in February with a term-sized fibroid uterus with intermenstrual bleeding. A DNC was done in March. Please take a note of this timeline because it is going to be important later. This March is not important. Later when some active intervention is done, what happens? Just see. DNC was performed in March to rule out endometrial hyperplasia and any other abnormality which might be concurrently present with fibroids to cause this abnormal uterine bleeding. Now, somewhere around 5 months after that, on August 12, the patient underwent a total abdominal hysterectomy with bilateral salpingo-oophorectomy. The preoperative diagnosis was fibroid uterus and menorrhagia, and the postoperative diagnosis was the same, but the villain strikes again along with pelvic adhesions. A TH with biaso with lysis of adhesions, as I have told, was performed, and she was transferred to the gynec floor and remained stable with complaints of abdominal pain. 2 days post-operative, on August 14. Remember, she was operated on August 12. August 14, she was started on clear fluids, well tolerated, and her abdomen was mildly tender, which was expected post-operative. Overnight, however, she began vomiting, although her abdomen was still soft and without distension. She approximately lost about 1 liter of fluids the following day through the vomitus, and her abdomen now became distended with positive bowel sounds. A nasogastric tube was quickly passed as was expected, and about 1 liter of bilious fluid was suctioned out with some relief of symptoms. This was August 15. August 12th, she was operated. August 15th, this was done. An abdominal X-ray on that day was consistent with the post-operative ileus or a partial bowel obstruction. These two diagnoses were kept in mind. Post-operative ileus, people usually give a trial of conservative management. And early partial obstruction also, because there are adhesions, now there might be deforming or somewhere it has got entangled, it will free itself. But the time was running out. On August 17th, 2 days after, a repeat abdominal X-ray revealed dilated small bowel loops. The nasogastric tube was replaced and renal and surgical concerns were also requested because her urine output had gone down. The surgeon opined that the patient was dehydrated because she was passing so much in the nasogastric tube and she was still vomiting, which caused the electrolyte disturbance, and that also caused a reduced renal function. The nephrologist concurred. The differential diagnosis was small bowel obstruction. Once the patient was hydrated with improvement in her urea and creatinine, surgical consultation was planned again, and the surgical consultant told that we take the patient back to the operation theater. This is an intermediate period where she has paused. This small bowel obstruction is not going to yield to conservative management. Let us not waste time. August 17 has already occurred 5 days. Surgery was decided. But somehow, in this decision also, though she was taken to the surgical ward, 1 day passed in between. And it was on August 19th morning that the patient underwent surgery by the surgical consultant with a pre and a pre-operative and a post-operative diagnosis of small bowel obstruction. According to the operative report, after the exploratory laparotomy, lysis of adhesions was done, repair of enterotomy was done, and then there was a small umbilical hernia which was also repaired. But the surgeon's operative note indicated that a pinpoint opening was found in the area of small bowel tucked into the left side of the abdomen. Although there was no specific area of transition, these loops of bowel were obviously adhered, and they adhered here. Or we don't know. Who perforated the bowel? Was it primarily during the surgery? Or now when the surgeon was trying to open up, that this small pinpoint hole might have occurred? Whatever it was. She was ultimately discharged, went home on 31st of August, but required a wound care with the surgeon. And by December, she had fully healed and was then after completely active. So what started in March, the main intervention in August, mid-August, finally ended in December. Question still remains: who perforated the bowel? Not very important, but in a way important. So friends, in our clinical practice, many times post-operatively, situations arise where like this. They are called googlies in cricket, where if you can see here, the ball is pitched right on the offside and it flicks off the leg stump. How much it turned? What a brilliant bowling, you can say. But this brilliance is not desirable in clinical practice of the situation. But the brilliance of the doctor is required. Because when such a situation arises, we feel deluged. We feel very stressed. That is the time it is said, ask for help. Help is always available. Ask for help. And professionally manage the situation. If we professionally manage the situation in a timely way and a correct way, then the end will be where you can dance. You can be happy all along. Thank you, ladies and gentlemen. Thank you very much.